Welcome back. Let's go ahead and start talking about triple negative breast cancer. So, with regard to triple negative disease, uh, what I want to say here is that first and foremost, if an individual is diagnosed with triple negative breast cancer in the early stage setting or locally advanced setting, we can do a good job of addressing those early stage or locally advanced tumors with surgery and chemotherapy. However, unfortunately, triple negative disease is associated with pretty high relapse rate. So when it comes, when it comes back, it's going to come back and it's going to be metastatic because we're addressing the primary site. Since it is triple negative, chemotherapy remains the mainstay of treatment because we can't use endocrine therapy and we are not using HER2-directed therapy if it's a bona fide triple negative cancer. However, what I will tell you is that when that disease comes back, it's a good idea to reassess the tumor for possible discordance between the primary and then the metastatic lesion. Just because it was triple negative in the primary, months or years ago, doesn't mean that it's still triple negative. There's a chance that the tumor could have evolved and started to express the estrogen receptor as a driver. There's a chance that it might express the HER2 receptor on the surface. We also want to make sure that we know the BRCA1 status, right? Because all of these are predictive biomarkers. Right? They will predict response to endocrine therapy, HER2-directed therapy, or PARP inhibitor therapy. Now, historically, chemotherapy has been the mainstay of treatment. And when we use chemotherapy in a triple negative metastatic disease patient, we typically go with one drug, just one single chemotherapy drug. Uh, Using more than one didn't improve survival historically, and it added side effects. Right? So the only time we would really use two drugs in the triple negative metastatic setting is if the patient was very symptomatic from their disease and we needed to induce a rapid response to help with lung or liver issues or some other associated adverse effect from the tumor. So we would start off with the taxane, and then we would use the taxane until the patient was unable to tolerate it or until the patient had disease progression. And then after the taxane, we would pivot to something else like an anthracycline. And then we would continue to do this until we kind of run out of options at that point. However, within the last couple of years, there's been a lot of investigation in the triple negative setting, specifically questioning whether or not immunotherapy with pembrolizumab, the immune checkpoint inhibitor, combined with chemotherapy can benefit individuals with triple negative disease. So there was a study done a couple of years ago called the Keynote 355 study. And what Keynote 355 did is it investigated whether or not combining pembrolizumab with chemotherapy versus chemotherapy alone improved overall survival. That was the question that the researchers asked. And so what they did is they took patients with triple negative breast cancer that was metastatic, and then they randomly assigned them to pembro plus chemo versus placebo plus chemo. They did do some subset analysis here. Right? And they looked at something called this combined positive score. Combined positive score means you look at the tumor sample and you look at all of the cells that are positive for PD-L1. This includes the tumor plus macrophages plus lymphocytes, anything that's PD-L1 positive, right, gets added up, and then you divide that by 100 live tumor cells, right? And then you multiply it by 100 to get your percent. And if the CPS score was greater than 10, or the CPS score was less than 10, they did a subset analysis on that arm of the study. And what they found is that overall, pembro plus chemo, it gave an overall survival of about, 23 months. And then placebo plus chemo gave a 16-month overall survival. So the addition of the pembrolizumab improved overall survival. And it was more pronounced for this group, the individuals who had a CPS greater than or equal to 10, because PD-L1 expression is predictive of response to pembrolizumab. These folks over here didn't do as well. Okay. So immunotherapy in the form of pembrolizumab plus a taxane for select patients is now a very, very strong treatment option for the triple negative setting. Also, knowing if the patient is BRCA1 or BRCA2 mutated, germline mutation, predicts response to the PARP inhibitors or even platinum agents for that matter. And we talked about that early on. So this is what's done sort of in the upfront setting. For second line, there are a couple options. For second line therapy, progressive disease, there's an antibody drug conjugate molecule called sacituzumab govitecan. Right, this is Trodelvy is the trade name. And sacituzumab is a monoclonal antibody that targets an antigen called TROP2. And then govitecan is a topo-1 inhibitor. That particular molecule is indicated for progressive disease in the triple negative metastatic setting. And it's being used quite often, I understand. Also, one other drug that we'll talk more and more about here moving forward is a drug called Enhertu or trastuzumab deruxtecan. Again, trastuzumab goes after the HER2 receptor, and then deruxtecan is just another type of topoisomerase 1 inhibitor. This particular molecule is indicated in triple negative disease that is HER2 low, meaning it's 1 plus on the IHC. The immunohistochemical analysis only reveals 1 plus or 2 plus and then FISH negative. So again, too, when they look at the slide and look at the staining, if it's 2 plus, again, that is equivocal. And then the reflex is to do a fluorescence in situ hybridization study to look for the actual number of HER2 genes. And if it comes back negative, then it's technically HER2 negative, but these have been reclassified as HER2 low. And we can use a drug like trastuzumab deruxtecan in this HER2 low setting for triple negative breast cancer. This is right out of the guidelines, again, to systemic chemotherapy for hormone receptor negative, HER2 negative disease. This would be TNBC, which we're talking about right now. Okay. Single agent chemotherapy in the form of an anthracycline like doxorubicin, in the form of a taxane like paclitaxel. We're using any of the antimetabolites, capecitabine, the prodrug of 5-FU, or gemcitabine for that matter, right? And we would continue any one of these until the patient can't tolerate it or until they had disease progression. And then we could pivot to the next one and to the next one. Right. Useful in certain circumstances are these combined regimens, and this is where you would use two drugs to help address severe symptomatic disease. And then I'll just direct your attention to this bottom frame on this slide. And again, to triple negative breast cancer, again, HER2 negative and hormone receptor negative, right, in the first line setting for a CPS greater than or equal to 10. Right, these are the individuals that have triple negative breast cancer that has a good expression level of the PD-L1 marker on macrophages, on immune cells like lymphocytes and the tumor cells. This is predictive of a response to pembrolizumab plus a taxane or one of many other drugs. Okay, so this is what can be done in the frontline setting for the right patient population, PD-L1 expressors. If the patient has triple negative disease that has a combined positive score less than 10, and they don't have any germline BRCA mutations, the chemotherapy is what's recommended. So we default back up here. Okay. However, if the patient has a combined positive score less than 10 and they do have a germline BRCA mutation, they're going to respond probably pretty well to a platinum agent. You can use a PARP inhibitor as well. Because again, BRCA mutation, germline BRCA mutations predict response to PARP inhibition or platinum administration. Right? After your patient progresses on any of those, they will become a candidate then for sacituzumab govitecan, maybe even Enhertu or trastuzumab deruxtecan. Right? Right, that's triple negative breast cancer in a nutshell. When we come back, we'll go ahead and talk about how we address metastatic hormone receptor positive breast cancer. Talk to you soon.